Good morning, everyone, and welcome to the COVID-19 in Texas webinar series. I'm Ken Smith, Senior Health Policy Analyst at Texas Health Institute. Today's webinar is the Frontline of Behavioral Health, how local mental health authorities are adapting to COVID-19. Before beginning this webinar, some quick housekeeping. We are recording this session and it will be made available on our website following the webinar. If you have technical difficulties or questions, you can contact our THI convenings team via the chat box. Let me repeat that. Use the chat box if you have technical difficulties. Finally, we will be having a Q&A session at the very end. And so if you have any questions for me or the panelists, who I will introduce in time, you can insert those questions in the Q&A box. So use the Q&A box for questions of me or the panelists. Use the chat box for technical difficulties. Texas Health Institute is a nonprofit, nonpartisan public health institute based in Austin, Texas. Our mission is to advance the health of all, and we do so through our three areas of work: producing evidence and ideas, translating and sharing insights for action, and advancing collaborative action. We bring expertise across a wide variety of areas, including health equity, community health, transgender health, oral health, emergency preparedness, and so on. This series is a foundational part of our commitment to playing our part as the state's nonpartisan public health institute to help inform and guide our state's COVID-19 recovery and response. This series, and I just want to say that today we will be focusing on the impact of COVID-19 on behavioral health in Texas, and we have two esteemed guests who will be providing insight from the front lines. So first of all, this is the flow of the webinar. Coinciding with today's webinar, we have also released an issue brief serving as a call to action to address the behavioral health issues that have emerged during the pandemic. And so the first thing that we'll do is I will be providing a very brief overview of the issue brief and some key takeaways. And that will provide the foundation for you guys to sort of understand what's really going on in Texas. And then I will turn it over to our two guests to provide their insight on these kinds of issues. And finally, we will have an opportunity for Q&A, time permitting. So first of all, COVID-19, the pandemic response to requiring social distancing and the ensuing economic downturn have generated a great deal of anxiety, sadness, grief, and stress. In June of this year, a national survey found that 40% of U.S. adults were struggling with mental health or substance abuse. The trends on the right show that U.S. adults report symptoms of anxiety disorder and symptoms of depression with increasing frequently from April through July. So you can see the U.S. adult population trend going upward with symptoms of anxiety disorders in the top panel, and Texas's trend following the national trend upward during this period of time from April through July, except we're above the U.S. rate. And in the bottom panel, you see symptoms of reporting anxiety disorders. So it's depressive disorders in the top and anxieties in the bottom. Now, it should not be a surprise that a prior behavioral health diagnosis would be associated with a greater risk of symptoms of anxiety and depression during this pandemic. This slide shows that a prior diagnosis of PTSD greatly increases your risk for not only symptoms of anxiety and depressive disorders, but also initiating and increasing substance abuse and suicide ideation. So let's unpack this a bit more. Now, keep in mind that 11% of U.S. adults considered suicide in the past 30 days in June, if you look at the last four bars in this chart. And so, but that jumps to 44.8% among those with a prior diagnosis of PTSD. So now, let's look at these socio-demographic risk factors. There are some interesting disparities in suicide ideation, whether or not people have considered killing themselves within the past 30 days. And what we found was very surprising in that 31% of unpaid caregivers considered suicide in the month of June. That's very disturbing, but we also find some interesting other kinds of socio-demographic correlates. Those with less than a high school education and essential workers were also affected disproportionately with suicide ideation. Now, it's important to realize that what's going on with this pandemic with mental health is not just something that's occurring in the short run. I expect that these changes will permanently shift the demand for behavioral health services in the U.S. Now, first of all, one disturbing factor in the pandemic is increasing reports of intimate partner violence and child maltreatment, which is discussed in the issue brief. Now, this is a global phenomenon, but many of you have probably been hearing it in the broadcast media. But what's important to note is that COVID-19 associated increases in adverse childhood experiences, basically child abuse, these ACEs are associated with an increase in risky behaviors and poor physical and mental health outcomes over the life cycle. So as a result of what's going on with domestic abuse, there's this is not just going to go away for these kids. It's going to haunt them for their throughout their adult lives. And so there are a lot of long-term mental health effects for the survivors of the pandemic, including not just those who have survived actually having the disease, which itself can be very traumatizing, but those who have had to live through the trauma of unemployment, housing difficulties, food insecurity, and of course, abuse. So one of the chief takeaways in the policy brief is that there is a shift in the demand for behavioral health services in both the long and the short run. The second takeaway is, of course, barriers to access to behavioral health services. Now, this is something that has been going on before the pandemic, but the pandemic sheds a lot more light on this issue. If you look at these maps of behavioral health providers, the white areas are areas where there are none of those providers. So there are large swaths of areas where you can drive for hundreds of miles and not see a psychiatrist. Drive hundreds of miles and not see a psychologist or even a licensed professional counselor or chemical dependency counselor. And then if you do, it may be too costly, which also limits your access. And in some cases, many providers won't accept insurance, they'll only accept cash. And oftentimes that's too expensive. Another important takeaway about barriers to access in Texas is mental health stigma. And even today, even though we know that mental health has the same kinds of problems as physical health, that there's no difference, that even despite all the knowledge and awareness we have as professionals about mental health as being just like any other kind of physical problem, there's still a lot of stigma around it. And there are variations across different groups in the level and the nature of that stigma. But when you feel stigmatized, you may be less likely to seek access, may be less likely to have that awareness that whatever you're feeling is something that you might benefit from some counseling or some other kinds of supports. One way of addressing some of the stigma, particularly with outreach, is to ensure a diverse behavioral health workforce and to ensure that the workforce that we have right now are sufficiently trained in cultural and linguistic competency. So this is another kind of access barrier, and given the diversity of the Texas population, it's something that we really need to pay attention to in the long run. Now, we also came up with some recommendations. For time, I'm not going to go deep into this, and maybe we'll have an opportunity to talk about these with our guests. The first one is to utilize peer support specialists for outreach and education. These could be lay workers, particularly from the communities that they serve and speaking their language. The second is removing barriers to telehealth and increase Medicaid reimbursement rates to address some of those access issues around distance and cost that I talked about earlier. Third is to implement best practices known to reduce COVID-related morbidity and mortality. And there are different kinds of models of care, integrating behavioral health care with primary care, things of that nature. And again, I'll leave it to the experts to talk a little bit more about that. And then finally, you know, we at Texas Health Institute would like to have a call to action for everyone in Texas to really begin addressing mental health stigma and to work to increase the diversity of the behavioral health workforce. So I hope that you guys will have an opportunity to read the issue brief. It is brief. We try to keep it brief. And it will be made available to you after the webinar. So now I'm pleased to introduce our guests. Our first guest is Greg Hench. And Greg Hench serves as the Executive Director of NAMI Texas. He joined NAMI Texas in 2012 and has also served in the roles of Public Policy Director and Policy Coordinator. In his current role, he is responsible for providing direction and leadership towards the achievement of NAMI Texas's mission. He is an alumni of the Policy Academy of the Hogg Foundation for Mental Health at UT Texas. And Greg's picture is the third there. Our second guest is Lee Johnson, the Deputy Director of the Texas Council of Community Centers. And Lee has served for 12 years as Deputy Director, advising on legislative strategy, appropriations issues, strategic communications, and policy implementation. Prior to joining the Texas Council, he served as Legislative Director for a state representative. So, Greg, I will start with you. Please unmute your phone if it's been muted. Just a quick question for you. Tell us about NAMI and what your members are seeing with the pandemic in the communities they serve, and how are they adapting to these increased needs uncovered in this issue brief?
Yes, thank you so much. I appreciate the question, and I'm glad to be with you all here today. The report that you've shared and just presented on is really important, and it provides some really key insights and perspectives about the Texas mental health system. And I think that there's great potential for the report to be utilized in decision making in the upcoming legislative session. So as you mentioned in my introduction, my name is Greg Hench. I'm the Executive Director of NAMI Texas, which is the Texas affiliate of the National Alliance on Mental Illness. And we are a 501c3 nonprofit organization founded by volunteers in 1984. We're affiliated with NAMI on the national level. We are part of America's largest grassroots mental health network. And importantly, we have 27 local NAMI affiliate organizations throughout the state. And these organizations help us really keep our ear to the ground on what's happening across Texas and how issues like COVID-19 are impacting Texans with mental health conditions and their family members. And that is what our membership primarily consists of, about 2,000 people who are individuals with lived experience. And we exist to help improve the quality of life for people affected by mental health conditions. And we do that through our education programs and support groups and our advocacy work. We offer a variety of free mental health education classes, free support groups, and in our advocacy work, we address a wide range of public policy issues affecting Texans with mental health conditions and their family members. In any given year, prior to COVID-19, our programs were reaching thousands of people across the state. And so, the historical method for delivering those programs is in-person service delivery. We have mental health education classes for peers and family members, and we deliver those in a variety of community settings. And we have support groups. The same goes for those. And those programs are really all about leveraging like peer perspective and peer experience, and leveraging family perspective and family experience to help people navigate unforeseen challenges, provide people with hope for a brighter future, provide people with practical skills and tips that they can use to navigate their own recovery or support the recovery of their loved ones. So these programs that we offer that are at no cost to the participants are really essential components of mental health service delivery in the state of Texas. And your report, makes specific reference to the importance of peer-centric, peer-provided mental health services. And we're part of that, philosophy of the importance of there being peer mental health services. With COVID-19 coming around, we've had to adapt quickly to make sure that these services can still reach people in need. So we've made those services available online, and we had been planning to do that for quite some time anyway. So sort of the timing actually worked out pretty well for us. We were going to start doing online support groups in 2020 anyway, and COVID-19 really just accelerated our implementation of online support groups. And on any given day across the state, more often than not, there is a mental health support group or education class for peers and mental health support group or education class for family members right now in Texas. And that's an important resource, and we encourage people to access those resources, and they can visit our website, namitexas.org, and that's all, that's the only place you need to go to figure out how to tap into these support groups and education classes. And we've seen, increased interest in these programs. And I think that is in part because COVID-19 has put a spotlight on mental health. It's in part because a lot of people who wanted to join our programs before simply didn't have access before. And now that the programs are online, it creates new opportunities for people to engage. And I think that's true for telehealth and telephonic services, generally speaking. And also, another reason why we've seen such an uptick in interest in our services is that COVID-19 is causing new mental health challenges, as your report describes, or as exacerbating existing mental health challenges. And what we've been hearing from people who are either calling our office or who are longstanding members of our organization, we're hearing a lot of concerns about isolation, because people are subject to stay-at-home orders, and businesses and schools are closed. So, isolation is a hallmark feature of many mental health conditions already. And now that, the expectation is in essence that people isolate by not physically surrounding themselves with other people, that can exacerbate existing concerns around isolation or cause new concerns, and that's often tied in with depression as a mental health condition. So we're seeing a lot of that. We're seeing a lot of increased stress and anxiety. We hear from people calling our office that they're really being thrown for a loop by what we're going through, and this isn't the healthy kind of stress. This is the kind of stress that causes people to stay up late at night. It throws their routines off. It causes them to just generally have difficulty navigating the day. So we've been hearing that issue a lot as well. And then as you mentioned in the report, job loss is a major concern that is tied in with mental health concerns. And we've seen through past economic recessions, when the unemployment rate goes up, that mental health issues rise right along with that. Suicide rates tend to rise when the economy is not doing well and when people are experiencing job loss. And then, obviously tied in with that is that we have a health insurance system that is, often tied to people's employment status. And, I'll never forget, this is one of the most stark and sort of jarring calls that I took during COVID-19. It was someone who was furloughed from his job and lost his health insurance as a result. And because he lost his health insurance, he couldn't pay out of pocket for the very expensive medication that is basically the cornerstone of his recovery. This is the thing, this is the treatment that completely turned his life around. And he lost his health insurance, couldn't afford the medication out of pocket, couldn't even come close to affording it. And he was worried about his ability, not just to continue to, experience a relatively high quality of life. He was worried about his ability to live, period. So it's issues like those that, really put a spotlight on some of the gaps in our system. The fact that we already have a high uninsured rate. We already have the most number of people who are uninsured in the nation. And COVID-19 is exacerbating a lot of those, again, existing gaps, existing disparities. And that's another thing I would say around health equity and disparities is, there are clearly certain populations that are more impacted than others. And we do hear, we hear more from people from marginalized communities. We hear from people who are on the front lines of provision of healthcare or who are in, low wage jobs. Those are the people who are most commonly reaching out to us looking for support. And it's because they have less access, and it's because they're more impacted by the mental health challenges caused by COVID-19 than, more privileged populations are.
Mm-hmm. Mm-hmm. Yeah, well, and, I think that you raise a very important point about, access to care and that person that you mentioned. It's, just, when you delay seeking care for any kind of physical disease, it really exacerbates the problem. And the same is true for behavioral health problems as well. And so, if people are not going to get their care soon during this period of time, then it's going to haunt us even more, which goes back to this whole sort of shift in needs as a result of Texas not being as prepared and the U.S. not necessarily being as prepared. So I'd like to turn it over to Lee Johnson to say a little bit more about the infrastructure in Texas and what we can do for both the short and long-term needs. So Lee, you represent mental health authorities. So can you please comment on what you're seeing and how you're adapting to the increased needs you and your the organizations that you serve and you represent?
Absolutely. Well, thank you, Dr. Smith. I'd just like to say very quickly before I start, thank you to you and your team and to the Texas Health Institute for putting together this event today and for the excellent issue brief that's highlighting some really important issues in our state. I'd also like to say thanks to my good friend Greg Hanch. NAMI Texas is a very important organization in Texas and has been a partner with the Texas Council for a very long time. So it's always a great day when I get to give a presentation with Greg. So what I'd like to do very quickly, if I could, I want to share just a very few number of slides to help visually depict the response to your question, Dr. Smith, because I think showing that impact is a really important aspect of this discussion. So the first slide here is a slide that I like to start with because it visually depicts where our system is located, and that's really all 254 counties of Texas. So community centers of Texas are statutorily authorized as units of local government, and they serve as the legal framework for our state's local mental health and intellectual and developmental disability authority designation. People may remember the historical reference of mental health and IDD centers or local authorities as MHMR centers. So you can see that they serve geographic regions across the state. This is what we describe as the public mental health and IDD system, and it serves everyone regardless of their ability to pay. So this next slide depicts what occurred in our system as a result of COVID-19 over a fairly short period of time, looking at about a 5-month span. And what it does is it shows the number of encounters by encounter type in adult mental health services. And so encounter types are telephone, audio only, telemedicine, telehealth, which is synchronous two-way video, and then face-to-face interactions. And so what this bar chart shows over time, beginning in January with that first bar on the left, is you can see that primarily most of the service delivery in our system for adults was occurring via face-to-face service delivery modality. And as the pandemic began to impact our state, you can see that in February and March, you start to see dramatic changes in the way that services are delivered. And then for April and May, you can see what looks like a very dramatic shift from primarily face-to-face service modality to audio only and telehealth and telemedicine modalities in the system. And really the overall view here is to demonstrate the fact that despite a global pandemic, the system was able to maintain access to services in adult mental health for Texans across our state in need. And then the next slide here shows the same view, but for children's mental health services. And you can see the same dramatic shift that occurred over the same time period from January to May. And really, quite frankly, in a dramatically short period of time, our system was taking advantage of the emergency orders that were put in place to allow service delivery to occur via these modalities, and really working feverishly to maintain contact and ensure access to care for folks that were relying on the public mental health system of care. And then the last slide that I want to show is just a couple of points to make on this. As a result of the pandemic, our system engaged in the typical partnership that we do with the federal government and the state government in what's called the Crisis Counseling Program. And this initiative is called Texans Recovering Together. And what it is it's administered with the Health and Human Services Commission's Disaster Behavioral Health Division, and provides short-term stress management and crisis counseling for individuals and groups having psychological reactions to large-scale presidentially declared disasters. So I'm fairly certain that most folks know that March 25th, the president issued a major disaster declaration for the state of Texas. And in response, the centers in our state, our members, partnered with the Health and Human Services Commission as part of our broad behavioral health disaster response role, and then submitted a grant proposal to FEMA. And so for context, what I'd like to do is just touch on the impacts that this crisis counseling program has had since it went live. So this data reflects data as of August 31st. But to date, there have been more than 5,500 individual encounters. There have been more than 9,500 group encounters, more than 919,000 contacts by phone, email, or through providing written materials. And this is a unique aspect of the crisis counseling program that's occurred during the global pandemic, with the dynamics that Greg was talking about in terms of social distancing that we've all experienced. We've seen more than 3.7 million reaches through social media contacts that have been made. This is the first time that social media has been used in this way through a crisis counseling program grant. And we're quite impressed and very happy with the ability to reach so many folks through that medium. And then on the right side of this slide, I want to provide this information to anyone that's listening that may need help. And I want you to know that this line is available for you. And I want to talk a little bit about what this is. So the COVID-19 mental health support line was launched by the Health and Human Services Commission in partnership with the Harris Center for Mental Health and IDD. And this is part of their efforts through the crisis counseling program. But what the line does is it augments local COVID-19 call lines and psychiatric crisis lines that are available 24/7 across the state, ensuring that Texan citizens can get access 24/7 to someone willing to talk to them through stressful situations that may emerge as a result of the pandemic. And so what the idea behind this is to ensure there is no wrong number for Texans to call. Each call line is able to respond to the immediate issue at hand, and if needed, the individual that's answering the call through this line can connect the person to a local crisis response system in their area. So for example, if someone calls the COVID-19 support line and it's determined psychiatric intervention is necessary, the person can be connected directly to their local crisis response staff serving the area that they live in. So this COVID-19 support line has been hugely important. And just a brief snapshot of the data for what we've seen so far. This is as of the 28th of this month, so just a couple of days ago. The call line has answered over 7,500 calls since it went live on March 31st. And calls have been received from over 184 counties across Texas. So these are resources that are available today and will continue to be available. And I would just encourage anyone, feel free, please share this information with anyone you know. I would strongly encourage, post this on your social media pages. Make sure that you're getting the word out about this so that more and more Texans can learn about it and know that this resource is available to them. And then one other point about the COVID-19 mental health support line is that it's also able to address the needs of first responders who are engaged and responding to the needs of folks in their community. So a lot of effort underway and in a very short period of time. And again, I say thank you so much for the opportunity to visit with folks today, and look forward to the rest of our discussion.
So I just want to remind everyone that if you have any questions, you can type it in the Q&A box. So I'm gonna first, I think I just saw someone asked a question through the text box and it was answered. So Greg, could you just say a little bit about rural access to internet and the importance of audio only? There was a question that someone just recently asked.
Yes, absolutely. Yeah, and the question that came in was, pointing to the circumstance that there is unequal access to internet connectivity across the state. So video-based telehealth is simply not a panacea to addressing access needs across Texas. One of the approaches certainly should be to expand broadband access across Texas, and that's one of our policy recommendations for the upcoming session. But additionally, a lot can be done through an audio connection, through a telephonic mental health service provision. I know that there are some billing codes that can be used for audio provision of telehealth, but there are some billing codes that cannot be. And I think that that's something that needs to be looked at, and it's something that I think comes up in the THI report, that we should, be considering requiring that there be some degree of parity between video telehealth and audio telehealth. And I'll also mention just, briefly on one, very effective model for providing mental health services is the collaborative care model. And, the report talks about that as well. And collaborative care model can, utilize an audio telephonic consultation. And what the collaborative care model is really all about is leveraging the primary care system, and integrating some degree of behavioral health services into the primary care system. And it's often what is being integrated is a telephonic consultation with an off-site behavioral health professional. So, and the report talks about this, but I'll just say that I think the collaborative care could be a real game changer for access to mental health services. And in fact, if it is implemented universally across Texas, it will save lives and improve quality of life.
Yeah, and Dr. Smith, if I could weigh in just a moment on the access to broadband. It's been a very interesting dynamic in that so many of the conversations that we're having in the healthcare space today revolve around access to broadband. I think in the last legislative session, Chairman Price out of the Amarillo area it passed legislation to create Governor's Broadband Council. And I know that they're in the middle of developing some recommendations, and a report will be released fairly soon, I believe, hopefully before the start of the next legislative session. And it's an interesting time that so many folks in healthcare are now talking about the lack of access to adequate broadband capacity. And how much of that has been driven in large measure by experiences across rural Texas where we don't have sufficient infrastructure. And so to Greg's point, I think he made a very important one, ensuring that there is still the ability to reach people with audio only modality is really key. And as a system, you saw that in the data I provided a moment ago, and not just for areas that are challenged with access to broadband, but for example, in large urban communities, when you are attempting to maintain connections and access to people experiencing homelessness, that's been a hugely important area that our system has engaged to provide, for example, prepaid cell phones in instances where we were trying to maintain connections with people experiencing homelessness. So the audio only modality has been hugely important, but I think our state will be faced with a next step conversation. And we certainly have leaders that are in the legislature who are well positioned to do this with lots of expertise about broadband. But it will be a conversation that begins to require the participation of people that have been in healthcare space traditionally. We're going to have to figure out solutions as a state that can ensure that every community in Texas has access to broadband.
Great. Well, thank you. I do want to point out that someone asked for a link to the flyer for the COVID helpline, and I think it is in the chat box, but we'll also provide the link in the follow-up for this webinar as well. Great, thanks. And feel free to disseminate that information throughout your networks. Someone has a question about learning more about screening tools. Greg, do you have any information about where someone can find screening tools for anxiety, depression, and suicide ideation?
Yeah, so the screening tools and assessments aren't really an area of expertise for me. However, there are some just free screening tools that are actually available online. So you don't necessarily need to be screened always by a mental health professional, in person or through a telehealth connection. There are, if you go to Mental Health America and their website, there are some free online screening tools for anxiety and depression that can just be a useful tool in seeing if there's maybe something going on under the surface that then would trigger a closer look by a mental health professional and a full assessment. So I'd recommend checking out Mental Health America's free online screening tools. Okay,
so sure. Someone did just want to make a note that someone suggested contacting your legislator or Governor Abbott about broadband access. And someone else has also talked about seeing those slides. And I just want to remind you that all the slides will be shared in the follow-up, including Lee's slide. So that will be there. Let's see. I see Maddie has a question. Have you seen any unique changes in substance use patterns? Greg and Lee, we talked about this a bit, and she also alludes to issues around supply chains and supply lines interrupted, so drugs may not be available, those medications may not necessarily have been available. Have you seen any of those kinds of issues?
Well, I think, the person that asked the question is insightful on this because, we do not have data collected yet. But what we do have is data that's showing prevalence rates and what happens when our country experiences an economic downturn. And so projections can be made. And I know there are a number of organizations that have put together, some forward-looking data runs and estimates that are showing what that future might look like from an increase in substance use and other situations like that. I know that the Meadows Mental Health Policy Institute has put together a paper on that. I know that there are a couple of other foundations that have done that work as well at the national level. And so I think, the evidence that I've seen, while we don't have data to actually show this experience yet, I would say that there are credible sources that have provided estimates that we will experience, a pretty big influx of demand for substance use services, but also for mental health services as, some of the dust settles in terms of the immediate response of the COVID-19 pandemic. This is certainly going to be a long-term reality for mental health providers across the state. And likely across the United States as well.
I have seen data suggesting that overdose deaths are rising during COVID-19, and that's a very concerning trend. And it's important to remember we had a pre-existing overdose epidemic to begin with, and now COVID is causing those rates to go even higher. So I think that this needs to be a key priority in the upcoming legislative session. And one of the policies that we're advocating for is for there to be a statewide Good Samaritan policy that provides protection for people who are calling 911 in the case of an overdose emergency. It sort of shields them from criminal liability in certain cases where they're calling 911 if they're concerned about an overdose. And those policies are proven to prevent overdoses, and we need one across the state.
I was just going to say, I would just add to what Greg said, and I think that, as we look ahead to what the legislative session, the 87th legislative session looks like, it begins on the second Tuesday in January of 2021. The state is grappling with a very difficult budget shortfall in the current biennium of about $4.6 billion. We're anticipating that the Texas Comptroller will release a revised revenue estimate ahead of the beginning of the session in January that could show, a much bigger shortfall that the state will be grappling with. So it's very difficult news to deal with when we anticipate such growing demand in the future as a result of what's occurring in COVID-19. So, I would just say that it's incumbent on everyone listening today to do their part to communicate with their elected officials to make sure that they're educated and understand the importance of maintaining an investment in mental health and substance use services and intellectual disability services as well in Texas.
Let me just turn this to a little bit something a little bit different, which is the issue of cultural competency and linguistic competency and outreach. And to what extent are we equipped in Texas for dealing with language issues? Like Houston, the city of Houston itself has like tons of different languages. And then how are your members dealing with this whole issue of stigma, and how can outreach workers address some of the stigmas which often are culturally based?
Sure. I'll jump in on that, and then I know that Greg will offer some good perspective on this as well. I will say that in the crisis counseling program grant that I discussed a moment ago, there's a heavy focus on cultural competency. And just with that alone, for example, when I mentioned the social media contacts that have been made, over 3.7 million of them, those contacts are being made in English and in Spanish. And communities are able to tailor those messaging items that are put out through social media to be able to tailor those messages to the communities that they serve. It's an amazing thing when you think about the diversity of our state. For example, the Harris Center, which serves all of Harris County, at a time, this is a few years ago, I was talking with someone there, and they described providing mental health services in 8 different languages. So, I would say there's always more work to do on this front, because I think it's absolutely essential that we're figuring out the best ways to reach the communities that rely on the public system. And so, there's always more work to do on that front, but I think we have to be focused on this. It is one of the most important areas of our system, especially when you think about the impact that stigma has and how stigma impacts different communities. And so the tailoring of those messages and ensuring access in multiple languages is really, really critically important.
Yeah, and that is so true. It's such an important point that stigma impacts certain communities more than others, and those are the communities where investments in stigma reduction and actually let's take a step further and say stigma elimination should be made. And there's some good work being done, and I think that one of the strategies that we need to be trying in combating stigma is reaching out to and training people who are trusted and respected in underserved and underrepresented communities. I'm talking about like faith leaders, for example. Like faith leaders can play an important role in busting the stigma of mental illness and encouraging the participants in churches and other faith communities to engage in needed mental health services. And oftentimes, like when a person or a family may be identifying a mental health concern, they go to the faith leader, and the faith leader isn't really sure what to say or where to refer people. So we need to be engaging with people like faith leaders, training them on what mental illness looks like and what the realities of mental illness are, and then, using them as a touch point for people who look to the faith leader as a leader and as a source of hope.
So last question, dealing with the same issue, which is, are we cranking out enough students, enough minority students, enough, new physicians who specialize in psychiatry in Texas? And what are we doing to expand some of these programs, and what can we do to, encourage people from different backgrounds to pursue, these kinds of professions in behavioral health?
Well, I mean, the short answer is no, and more work needs to be done. I would say that, we've had the benefit of some really great initiatives over time. And I look back and think about legislative history around loan repayment programs that were championed by Democrats and Republicans in the legislature. These are really truly bipartisan issues, and that's one of the best aspects of our work today in the environment that we're in. Because, I think about folks that have in the legislature championed loan repayment programs for multiple levels of clinicians. So not just physicians, but licensed professional counselors, licensed master social workers, that kind of an opportunity is hugely important. And especially when a clinician can go to work in the public mental health system and really get a passion for it in that early stage of their education, particularly with medical residency training programs. Other leaders in the legislature have made sizable investments in those residency programs. We're seeing that play out right now for children's psychiatric services in the initiatives that are underway with the mental health consortium that was passed in the last legislative session that's focused on developing child psychiatry and creating residency training programs that partner teaching hospitals and other university medical education centers with the community mental health system in Texas. And again, if you can train a physician in the community, they get a passion for it. And when they're, when they become a full, licensed, signed, sealed, and delivered doctor, they want to stay in the community and they get that strong passion for the work. And so our system has been really involved in trying to grow that. And so much more is needed there. And I view residency training programs and loan repayment as really kind of longer term, future oriented solutions. And we've got to keep focused on that and stay investing in those programs that are really effective.
Yeah, agreed 100%. And, additionally, I think we need to be making better use of peer services. And as, discussed in the report, peer services can and often do play a very important role in the mental health system, but they're badly underutilized. And really are deserving of more investment, especially as we learn more and more about the evidence base supporting the efficacy of peer services. So, for example, we should see the Medicaid reimbursement rate for certified peer specialists increase yes, so that it's a more well-utilized option. And we need to increase other Medicaid reimbursement rates as well to really pay people what they deserve. That's one of the key learnings, I think, from COVID-19 is that we undervalue people who are on the front lines of meeting basic human needs. And we should be paying, individuals who work in the healthcare system and who work in, under other, sort of underpaid jobs, paying them what they deserve for the important work that they do. We should be utilizing advanced practice registered nurses more. What an advanced practice registered nurse can provide is very significant. And, they don't have quite the training level of a physician, but they can do a lot. And we need to remove regulatory barriers that keep APRNs from practicing to the full extent of their training and licensure.
Yeah, and I would just add what Greg said. I really appreciate the fact, Dr. Smith, that the issue brief highlights the first recommendation as utilize peer support specialists for outreach and education. I mean, the point Greg made, we could not underscore that more. Our system across the state has largely very embraced peer services for just that reason, because of the workforce challenges that you showed in your slides earlier. Utilizing peers that have lived experience is a great way to interact and engage people that are perhaps reticent to engage in services. And it shows a path that other people can find recovery. And so I just very much appreciate the fact that, increasing access and utilizing peer support services is the very first recommendation in your issue brief.
Well, thank you. I think that we're running out of time. And so in the interest of time, I will ask if there are any additional lingering questions. We have time for one. And if I don't see one, then I think that we will move on. So I'd like to thank all of you for joining us for today's webinar. We're especially grateful to our panelists for taking time to be here to share their rich perspectives and insights. This is really great. Greg and Leah, thanks again for providing your perspective and all the information. This has really been great. I'd also like to thank the participants because many of you were sharing information out there, and we'll be sure to provide some information in the follow-up. And of course, I'd like to thank our THI team for their tremendous contributions to the issue brief and the behind-the-scenes work to making this webinar possible. You see all of my colleagues there. So finally, please join us for the full COVID-19 in Texas webinar series. Our next one is scheduled for October 8th. It is about using a health equity lens to ensure COVID-19 response and action for transgender and gender diverse communities. So that should be very interesting. And to register, please visit the link provided. Our team will also include it in the chat box. And so I think you can see it there in the chat box. So thank you again for joining us. And please don't forget to complete the quick post-webinar survey. You'll be receiving a link to the survey and to the issue brief and lots of other fun things. And again, thanks for participating. Y'all have a great day.
Thank you guys so much. Take care.